Dr. Bartley Griffith é cirurgião cardíaco e professor na Universidade de Maryland. Ele foi pioneiro nos 2 primeiros casos bem-sucedidos de transplantes de coração de porco geneticamente modificado para humanos, realizados em janeiro de 2022 e setembro de 2023. Recentemente, Dr. Griffith concedeu uma entrevista ao Dr. André Lupe para o Boletim Científico da Sociedade Brasileira de Cirurgia Cardiovascular.
We are basically bound in the process by the regulatory process. So, as you know, the procedures currently in the United States, the kidneys as well, have been under the guise of an EIND, which basically is expanded IND, and that's a term that we used to use. The word compassionate IND, and that for some reason it was changed to expanded. So in order to qualify a patient for an EIND, at least in the cardiac world, those patients must be shown to have no alternative that might be better than an experimental transplant that you are proposing. Their continuation of medical therapy is likely to result in a poor outcome very soon. They don't apply for standard human allotransplant because of complications or morbidities, and they don't also seem to be candidates for a ventricular assist device. So by the time you exclude patients who can have a VAD or an allotransplant and are basically dying, you end up with a very small number of patients, right? And those patients who are willing and can give consent are very few. Our patient that we did first was in the hospital for over, I think, like 60 days before the transplant, of which 50 of those days he was in bed. And of those 50 days, the majority included the use of VA ECMO just to keep him alive. So, you know, his alternative was very, very poor. And most people have judged that he was too sick, probably, to benefit. The reason that he was on ECMO for so long was that it took us a month to get permission from the FDA to go forward. And not only the FDA, but our own hospital, and to find out a way to pay for the procedure. So those 3 checkboxes, FDA, hospital, and payment, were necessary to accomplish, and it took a month. And the whole time he was getting sicker, weaker, thinner, you know, and less robust in order to have the transplant. We came close to canceling because we felt that the likelihood was not good that we would benefit. On the other hand, we had no trouble rationalizing that continuing medicine was just as bad. He wanted at that point to go forward because he was excited to contribute. And he knew, as did our second patient, that in all likelihood, the benefit would come to us and to your audience if he said yes, as opposed to himself. Meaning he did not expect to survive long term, such that he could compare his life to somebody with a human heart transplant. Mm-hmm. So all of those things set us up for a patient on the first round who wasn't, you know, quite good. And in fact, his bone marrow was quite depressed. He had resting white blood cell counts of about 2,000. And anytime we gave him an antibiotic, it seemed to reduce to about 500. So we had to limit our immune suppression significantly during the course of his treatment, such that it really didn't look like the non-human primate studies that we had done, in which we were able to fully load MMF and other kinds of drugs that are known to affect the bone marrow, but are very important in B cell regulation. So the first patient, took a while to get going. Then once his course was able to be evaluated, we went back to the FDA for a second patient. Now, the second patient was at home. Yay, and so we felt maybe he wouldn't be as sick. Well, by the time we got permission, which again took almost a month, the patient at home had to come into the hospital, and he had 2 arrests in the hospital from ventricular fibrillation. And his lungs, whited out with pulmonary edema. He had some acute kidney injury, which partially reversed. So he was also desperately ill. And in fact, when he went to the OR for the transplant, he had a cardiac arrest on induction of the anesthesia, more precisely with the sternotomy. He was saved, but and we got his heart into him. So that process of regulatory approval required that we give testimony to everyone, our local hospital, our IRB, and our medical school, that we were prepared to do the work. And the FDA used our experience with the non-human primate, which extended to 9 months of success with a baboon receiving a genetically engineered heart from a pig. And we had lots of baboons that made it, 3 months, and a number of them made it 6 months. So we were at equipoise for these sick patients that they might do all right. Now, all of this activity is, we hope, in preparation for the standard IND, which will be necessary in due order for multiple patients to be exposed to this treatment. And our sponsor, which is United Therapeutics, is hopeful that at the end of that study, there will be commercial approval, right, in some format. So again, all this is, if you wish, foreplay to the main event, which will be a broader issue that many centers interested in xeno will hopefully join us in. Well, okay, so the transplant itself is straightforward. It's a heart transplant. It's hard to make it different. The pig heart anatomically is a little different. It doesn't line up quite as well, particularly when the atria are dilated in the human. The atria of the pig heart are smaller, and they're very close together, so that once you sew the left atrium in, it pulls the right atrium quite a bit away from the native human atrium. And so a lot of freeing up of stuff and nipping and tucking, if you wish, and excising excessive circumference of the human atria has been necessary. And in fact, it wasn't really anticipated. When we saw the alignment or misalignment in the first case, we kind of gasped. And we weren't sure we could make it work. Because we had been doing all of our transplants in the small baboons. And the baboons without heart failure were pretty receptive of, the heart from the pig that came from a 20-kilogram pig into a 20-kilogram baboon. And we just never had an issue. But when we stepped up with a bigger heart into the human, it did make a difference in malalignment. And I think the biggest issue was that the atria were enlarged. Okay, so we sewed it together, and these hearts have been protected with a non-ischemic perfusion system. And we learned this from the Germans in Munich, who had been working in this field as long as Dr. Mohideen, my partner, but had success with orthotopic transplantation up to 3 months that was published. And they demonstrated that they were using this Steen solution and a perfusion system, which was only modestly cold. It wasn't real cold, but it was 12 degrees, I think, and it was low pressure, 20 millimeters to the root of the aorta, which is important because most of the heart surgeons would have thought you'd have to give more pressure, but it was a blood-containing Steen solution, which was recirculated, and for whatever reason, the pig hearts loved it. The pig hearts definitely said, "Thank you, that's a great way to protect me." When we tried any other protection that did not include continuous perfusion of a blood-containing solution, we had trouble. Blood made a difference from just standard cardioplegia. Blood cardioplegia was better, but better yet and more reliable, completely reliable, was the ex vivo perfusion system. So we duplicated that, which we had so much trouble with before we used it in the non-human primates. We did the same thing in humans. And so both of these hearts just jumped off cardiopulmonary bypass, boom. And we almost never use inotropes in the pig hearts. We learned that early in the baboon studies, that the pig heart is very sensitive to inotropes. It gets very tachycardic and doesn't really seem to help it much. So we use some alpha agents to tighten up for pressure, but very rarely have required much else. So patients went to the ICU, and we had a lot of education for our nurses in advance. We have a great ID team led by Dr. Saharia here, and he had spent hours preparing the nurses to be sure that they had the ability to opt out because of the concern of zoonosis, and particularly some of the nurses that might have been pregnant, or planning to become so. They didn't really think there was an issue after the lectures, but they just preferred not to be involved. Overwhelmingly, more than 95% of the nurses in our unit volunteered to basically take care of our patients. So it wasn't a very big hurdle, but we did have to be sure that we had done the education. So we took care of these patients. I think we used standard isolation, a gown, gloves, mask. That's it. And then we began to get patients up very quickly. Both patients got out of bed like at 2 days. And began the long process of trying to get some physical therapy. Our first patient couldn't even hold his head up. And the big challenge was to get him from slumping over, and hold his head up high because he'd been in bed for so long. So we made some process. They got out of bed. The second patient was up in a chair playing cards and looked terrific. I remember I watched the Super Bowl in 22 with the first patient. Our physical therapist actually tried to get him to sing the national anthem. He had a terrible voice and it was very soft. You could hardly hear it, but we recorded it. I think it was actually America the Beautiful, not the national anthem that he was singing. But anyhow, so that was a joy. And the thing about this, Andre, was that I never spent any time with these patients that I didn't, upon leaving their room, kind of just think with amazement that these individuals were being sustained with a pig's heart. I mean, it's fantastic. And I still get a chill when we use allo hearts, and somebody is now dependent on another person's heart. Kidney transplant, liver transplant. I mean, right down the line, I think all of us in this field still are in awe of the wonder, right, of how we get away with this, right? Well, a lot has been accomplished in allotransplantation. God knows, I've been at it for 40 years, And before me, the work had started 15 years before I started on it. And so, after 50 years, you would think you're pretty good at something, or you shouldn't be doing it. And our allo work, as you know, hearts, kidneys, livers, 1-year survival rates are spectacular. And we're helping a lot of patients. So we can't use that same standard on xeno. So those of us in the xeno world do worry that xeno is trying to do something when others, in fact, like to qualify and learn from xeno, as we did with allo, is never going to happen because allo exists and there are alternatives now that didn't exist back then. So we did all kinds of patients that didn't survive early and we learned from them. So I think that the goal is so great if we get there, i.e., organs for everybody. We won't have to, not say you can have, people who don't qualify for heart transplants now because they're a little bit too old, they'll get an opportunity, right? Or they might have a cancer or something. We'll still have an organ for them. You just have to order it, right? And they'll be plentiful. So, we won't have to triage our patients with a lot of winnowing patients down to the very best if we're going to use pig organs. And I'm sure we'll use pig organs as bridges for a while. We'll learn more and more. And then, eventually these pig organs, we hope, will be a good alternative. I don't think they're going to be quite as good as the human because I think, structurally they'll change and maybe won't live as long if you wish, because pigs don't live as long. It's just going to be really wonderful to learn about it. But it's a great goal, right? To be able to say to a 76-year-old, we'll have your organ here, just like we'll have your hip here, right? On a certain day, please come in and have your transplant. We'll reduce transplant wait times and the whole thing is going to be, quite different. But that's a ways away. And even though we've broken the glass ceiling, both now in kidneys at your center and others, and now, with the heart here at Maryland, we have to keep up the work. And the nice thing, Andre, is when I've had the chance to go around and talk about this, and I've been invited places I thought I'd never be invited to, right? Even, and they think I'm great, right? I'm still the same person. We just, we're lucky to do this, but everybody is encouraging, right? Everybody in the field seems to think we're doing it the right way, at least for now. And so I would hope that your society would also say, okay, it's going to take some time, but they're learning, and boy, oh boy, we have learned a ton. Andre, you've hit upon a little bit of a sore point. I haven't talked a lot about it, but in our second patient, we barely had enough heart to accomplish the goal. And we had a big enough pig in terms of weight that you would have thought that it would have been perfectly adequate. It was a big pig, weighed 125 kilograms, or this one I think was 110 kilograms. And our patient was about 70 kilograms. We always do echocardiograms on the pig to be sure there's nothing malformed, because these genetically altered animals, they can have bad valves, and so we have to be careful with that. So we follow these animals with echo. But when it came time to assign that pig to our patient, it was the only pig available of that near size. So it was either that heart or none other. We were relying on the echo that was done by the sponsor. And when we received the echo, we found it not quite good enough for us to do estimates of left ventricular mass and overall size. Function looked fine. So we just made the guess that the size of the pig and we would get the animal here they brought the animal to our medical center, so we didn't have to travel, a long distance with the ex vivo, because that's the way we had done the first one. We just felt more comfortable, even though I think we could travel without trouble. So when the animal's heart was explanted here, we did another full echo, and it seemed pretty small. But we calculated stroke volume, which is reasonably easy from the echo. And then we were able to do calculations of left ventricular mass. And it was within the range of what a human left ventricular mass would be for our recipient, but it was on the lower range. When we took the rascal out of the pig and held it up, it looked like you could have put it in a coffee cup. I mean, it was small. It looked small. And I kind of rolled my eyes. I said, oh my goodness, we had already committed on the patient. So off we went. And as I already told you, other than the fact we always have to mess with those atria, the transplant went pretty well, and we just came right off bypass, right? We didn't stay on ECMO on the second patient. We did that on the first because we didn't know what was going to happen for a while. The second patient, we didn't need ECMO, so we just came off. But in time, we learned we had to pace that heart at about 120 beats per minute in order to make up for a reduced stroke volume. So it wasn't ideal, and I think that heart was getting a little bigger, in time, stretching if you wish. But that's something we have to worry about. And please recall that one of the genetic alterations that the Revivicor pig has is a growth receptor knockout. It has 3 sugar antigen knockouts, but the 4th knockout is of this receptor, which is a growth receptor. And it was knocked out because the concern was that, these pigs generally grow to 400 pounds. And early in the experience, the wild type pig kidneys really couldn't be used in the baboon. So they needed to reduce the size of the growth, and felt that, they had evidence that the kidneys were overgrowing. So it was assumed that the heart would as well. And so there's a syndrome that I didn't know much about. It's called Laron's syndrome. And in that syndrome, there's a mutation at the same gene that was knocked out. And that mutation causes a syndrome of dwarfism in humans. So individuals are small. And so that was the goal, to have these genetically engineered pigs not grow much more than 150 kilograms, which is about their upper weight. Well, even at 150 kilograms, sometimes their hearts are pretty small and may not fit a large adult male. So for the time being, as long as that knockout continues, we may need to respect the fact that the Revivicor pig will be for no bigger than mid-weight patients. I believe there may be a plan in the future because of this to let that gene stay inboard and not knock it out. So only have 3 knockouts again. So we'll see how that evolves, because that's a decision that's made beyond my pay grade. I would like it if we had a little bit bigger hearts. Like any transplanter, you like a little more, not a little less.
Yeah.
So we learned that the smaller heart, relative to optimal, worked all right as long as we paced it. Now, the first heart was a little bigger, about 30% bigger in left ventricular mass. And we had no trouble with that heart in terms of, it had a heart rate of about 100 and, his heart rate was about 88 to 80 and did fine. And when we looked at the strain echo, the contraction pattern appeared to be pretty normal. Pig hearts are naturally thicker. And so, we think that afterload reduction is going to be an important strategy. The Germans noted this in their baboons, and I think it's a good thought. So, afterload reduction so that the heart doesn't have to work quite as hard is important, because pigs pigs generally have a lower blood pressure and a higher heart rate than humans. So if you ask a pig heart to work harder against a higher blood pressure, it may be that it will excessively hypertrophy. We don't know what'll happen, but we're going to try to keep it more like their native pig environment. We treat the patient just like you would a human transplant, perioperative coverage, and then we stop the antibiotics. And we try to be selective, to what we're going to cover. We do have a great new ability now to surveil for microbial agents, because we're now looking at cell-free DNA, and we're looking at not just the presence of organ damage, looking for donor DNA, but we're also able to trend and look for evidence of microbes in the blood. My guess is these kind of tests will totally change the way allotransplantation surveils as well for bacteria, because you don't need to culture. The test is available overnight, right? And so it's a lot easier to know and to keep an eye. And in fact, we found that PCMV virus in our first patient, which was nosocomial, we found it in the cell-free DNA, and we weren't sure it was real, but we learned it was ultimately. So those tests are really cool, and you can follow for viruses, and you can follow for all the bacteria that you might, tuberculosis, you name it, we can look for it. So we use that as a surveillance tool and help us, cone down on what antibiotics are going to be on. Now, our immune suppression is very different, at least induction. And with induction, we use ATG, we use anti-CD20, B cell suppression. We had not used TAC in our first patient, did give some TAC in our second patient, but have found that we don't see a lot of T cell rejection. We have focused the evolution of our immune suppression on the B cell and plasma cell, because we believe both patients passed from antibody-mediated rejection. And we do run our cross matches pre-op, right? And we wouldn't do a patient that had a high human anti-pig antibody, be it IgG or IgM. So we try to get humans that have low levels of pre-existing antibodies. But in spite of that, both of our patients had some antibodies against pigs, and it appeared that they were activated pretty quickly, and the plasma cells must have taken off. Rituximab does not affect plasma cells. I think you may know that. A lot of people, I didn't know that before I started doing this work, but you have to kind of think about that plasma cells. So we're beginning to evolve our work to include not only plasmapheresis, but more importantly, some of the drugs that have come out through the multiple myeloma treatments that will target the plasma cell. And whether they're protease inhibitors like bortezomib or carfilzomib, and or some of the anti-CD38s that will directly affect it as well. It doesn't seem to matter. We're working out protocols to try to help that. The basis of our therapy, though, was learned from the non-human primate work by Dr. Mohideen, and it was accessory pathway blockade, CD40. I know that the group in the Brigham also, at Mass General, excuse me, the Mass General group used that for their kidney, right? CD40 blockade using 154 ligand, I think, drug, as we did in our second patient. The accessory blockade drugs that are specific to 154 or CD40 are not currently available clinically. And so special arrangements are made to use those medications on a one patient basis. And we've been successful to do that. But our sponsor has been pretty adamant about when we get to the IND, they don't want to use non-clinically approved medications. Mm-hmm. They have their reasons, which are pretty good, actually. So we've been evaluating belatacept and tacrolimus as an alternative to anti-CD40. And there's some evidence from the kidney, particularly at Johns Hopkins, Dr. Yamada has shown that probably it'll work, at least short term. That belatacept and TAC is a good alternative to anti-CD40 blockade. It remains to be seen. Mm-hmm. The important message, I think, is we've got AMR, and everybody in the field knows AMR is hard to treat. That seems to be the major obstacle, and we're just going to have to learn how to take care of it. And we hope that after a couple treatments, a few months, the AMR will quiet, as you've seen happen clinically. We don't understand why all of a sudden you stop making antibodies, right? Mm-hmm. But we've got to keep patients and their organs alive during that period of accommodation. So that's the bet. And my guess is we will be talking in the near term, about strategies that will keep our patients going longer and longer. And they're going to have to be responsive to what we learn. I will tell you, Andre, we learned about the AMR mostly from, again, advanced diagnostics. And Dr. Alex Lupi from Paris, who does bulk transcriptomics, can turn it around really fast. He gives you wonderful genetic arrays, volcano plots, which shows what's going up and what's going down. And we've seen a very strong signal for AMR. There is some appearance of T cell activation as well. Philip Halloran from Canada out west is also following our biopsies, and he sees T cell activation. So even though I suggested AMR is the big battle, I don't think we'll ever be able to forget the T cell. And there's NK cells we have to worry about in this process, and lots of innate immunity. And then the last thing I will leave you with is we've seen complement staining early in our biopsies. And we thought we had adequate complement blockade. We learned complement blockade in the monkeys using snake venom, believe it or not. Well, that's not clinically available. So we moved, to Bayenert, which is an approved drug, but not very strong. And it blocks very high in the activation sequences. And we learned by taking serum from our patients and testing the serum for the active amount of complement blockade, we've learned that in spite of what we thought, we were not doing a great job at blocking. So our colleagues at Johns Hopkins in the Brodsky lab, Brodsky's an expert in complement. He works on hemoglobinopathies. And so we took our problem to him. He applied his test and he said, hey, you're not blocking. He said, but if you added this, it would block. Or if you add this, it will block. And if you use these doses, it'll block. So for the first time in xeno heart transplantation, we have something that we can actually measure that we're doing. You can't measure how effective the anti-CD40 is or, all these other medications, but that's a real advance. So if we get an opportunity to do a third patient, we will probably block high with a C1 blocker, and we'll probably block low with either eculizumab or a C3 blockade. And we'll do dual for sure. And then we'll measure how we're doing. I think the complement blockade is really important as part of the innate response to these things. And we got to get a hold of that. So better hold of the antibodies, even if we have to freeze pre-op, then use plasma cell pressure, better complement blockade, and maybe a little T cell sprinkled in, and probably not anti-CD54 or CD40, because again, we need a translational protocol for the INDs that we hope will start, within a few years anyhow. Yeah, there's always somebody who is going to be offended no matter what you do, right? In medicine, we find that the majority of individuals sense that respectful treatment of the pig donor is necessary, but that the pig donor is an adequate tool to use, because it's serving a noble purpose, just as you go to the store and you buy pig parts to eat. So while there are those who don't believe animals should be used either for any kind of experimentation or any medicinal, the majority of individuals agree that it's okay as long as it's done with the respect that the animal deserves. All of our animals are cloned. Right now, none of them have ever been outside the barn. And if you were to visit the facility, you would see how clean things are and how respectfully they are treated. Well, Andre, the Brazilians have always been at the forefront of medicine, and I've had great respect for a number of Brazilian specialists, heart surgery and, in efforts to treat Chagas disease and things that are endemic. A lot of lessons have been learned with ventricular remodeling, and so it's great to get to speak to your society. That's the first thing. And then I just think that those of us in this field have been humbled, and hopefully that will translate into remaining humble, right? We're going to get disappointments, but I hope we can make small steps. I can tell you, if we continue to learn in subsequent procedures what we've learned in the first two, this will be a very steep learning curve, and hopefully it'll translate into better outcomes soon.